Welcome to Teaching Service Hospital Rounds. Today we are covering ulcerative colitis. There are three words that carry this entire topic: mucosal, contiguous, and rectum. Ulcerative colitis inflames only the mucosa. It spreads continuously without skipping, and it always begins at the rectum. Hold on to those three, and most of what follows will make sense on its own. We will follow one young woman from her first clinic visit through her colonoscopy and her plan, and build the epidemiology, the extraintestinal disease, the diagnosis, and the complications around her. Let us begin. Ulcerative colitis is one of the two inflammatory bowel diseases, and telling it apart from the other one is where most of the exam points lie. Here is our patient. A 26-year-old woman comes to clinic with 8 weeks of diarrhea, and there has been blood in it from the very beginning. She is having 6 to 8 bowel movements a day, and each one is small. She describes constant turgency and tenesmus, that feeling that she still needs to go even right after she is gone. She has lower abdominal cramping that eases once she passes stool, and the stools wake her at night. Keep every one of those details. Each one is doing diagnostic work. She has lost 4 kilograms without trying, and she is otherwise a healthy young woman with no significant past medical history. She has never been hospitalized. Here is what you should take away today. First, define ulcerative colitis and separate it cleanly from Crohn disease. Describe the epidemiology and the pathophysiology, and recognize the classic presentation. Second, name the extraintestinal manifestations, because more than a quarter of patients have them, and know the severity scoring systems. Third, diagnose the disease with colonoscopy and histology, classify it by extent, and interpret the inflammatory markers. And fourth, recognize toxic megacolon and pouchitis, and state the colorectal cancer surveillance rule. Management by drug and severity belongs to its own video, so we stay on the disease itself today. Let us take the history. 8 weeks of loose stools, with blood present from the start rather than appearing later. 6 to 8 bowel movements a day, and every one of them small in volume. She has constant urgency, and a feeling that she never fully empties. She has nocturnal stools. She is up twice most nights, and she has lost 4 kilograms without trying. Now put those together. Blood, plus tenesmus, plus stools that wake her from sleep. That combination is not irritable bowel syndrome. Functional disease does not wake people up. Notice also that the blood was there from day one, rather than appearing after weeks of diarrhea. Now the rest of the history. She is 26, which sits right inside the first incidence peak for inflammatory bowel disease. Her maternal aunt has Crohn disease, so there is a family history of the disease family. She has never smoked. She has not traveled and has no sick contacts. She has taken no antibiotics in the past year, which lowers the probability of C. difficile, though it does not remove it. And her only medication is an oral contraceptive. So there is no obvious infectious or drug explanation sitting in front of us. And she takes no non-steroidal anti-inflammatory drugs, which can themselves inflame the colon. On examination, her temperature is 37.8 degrees Celsius. Her pulse is 98, and her blood pressure is 108/66. So she is mildly febrile and mildly tachycardic. Her abdomen is soft with mild diffuse, lower tenderness. There is no rebound and no guarding, and bowel sounds are present. And here is the part residents skip. The perianal examination is normal. No fistula, no fissure, no skin tags. That is a real finding. A normal perianal exam is a point against Crohn disease. Notice too that she is not peritonitic. There is no rigidity and no rebound, so we are not dealing with a perforation today. Her initial laboratory studies. Hemoglobin is 10.2 grams per deciliter with a low mean corpuscular volume, so she has a microcytic anemia consistent with iron loss. Her white count is 11,000 and her platelet count is 490,000. Her albumin is 3.1. Her C-reactive protein is 42 and her sedimentation rate is 55. And critically, her stool studies including C. difficile are all negative. Look at that pattern together. Anemia, low albumin, and a high platelet count. That is the signature of chronic inflammation. A reactive thrombocytosis like hers is easy to overlook on a printed panel. Let us get the definitions exactly right, because this is the distinction everything else hangs on. Ulcerative colitis is inflammation of the colonic mucosa. It is contiguous, meaning it spreads in an unbroken sheet. It always starts at the rectum, and it is confined to the colon. Crohn disease is transmural inflammation, meaning it goes through the full thickness of the bowel wall. It can occur anywhere from mouth to anus, and it produces skip lesions, patches of disease with normal bowel in between. 2 words separate them: depth and continuity. Say those 2 words to yourself every time you read a colonoscopy report. Look at the 2 panels. On the left is ulcerative colitis. Only the mucosa, the innermost layer, is inflamed. The submucosa, the muscularis propria and the serosa are spared. On the right is Crohn disease, and notice that all 4 layers are lit up. That is what transmural means. Now here is why this matters clinically. When inflammation burns through the entire wall, it can tunnel out of the bowel and form a fistula. It can scar circumferentially and form a stricture, and it can seed an abscess. Ulcerative colitis, staying in the mucosa, usually does none of that. Depth explains complications. Remember that, and the complication lists write themselves. Now the epidemiology. The first and largest peak of onset is between 15 and 30 years of age, which is where our patient sits. But the curve is bimodal. There is a second smaller peak between 50 and 70, and that matters at the bedside. A new diagnosis of inflammatory bowel disease in a 60-year-old is not unusual and should not be dismissed as something else. The male-to-female ratio is 1:1 in North America, and prevalence is increased in Caucasian and Jewish populations. Age alone never rules this in or out. And note the family history in our patient, a relative with Crohn disease. Inflammatory bowel disease clusters as a family, not as one specific diagnosis. Follow the chain across the screen. It begins with genetic predisposition, and prevalence is higher in Caucasian and Jewish populations. Then an environmental factor is added. A defective mucosal barrier is central, and smoking specifically raises the risk of Crohn disease. Those two together produce T-cell dysregulation. The immune system loses its tolerance to the ordinary bacteria living in the lumen. And that dysregulation drives chronic inflammation, which presents as ulcerative colitis or as Crohn disease, depending on where and how deep it settles. Genes load the gun. The environment pulls the trigger. Let us stay with the mechanism for one more slide. A healthy colonic mucosa is a barrier. It keeps trillions of luminal bacteria on the far side of a single layer of epithelium. When that barrier is defective, luminal antigens cross into the lamina propria. The mucosal immune system now meets bacteria it was never supposed to see. T-cells respond, and in a susceptible host, they fail to switch off afterwards. The result is chronic self-sustaining inflammation. And this is exactly why the disease relapses rather than resolves. The trigger, the bacteria in the lumen, never leaves. It also explains why we aim for mucosal healing rather than just symptom control. Now the clinical picture. The defining symptom is grossly bloody diarrhea. Not occult blood on a test, visible blood the patient sees. Alongside that come lower abdominal cramps, and tenesmus, which is the persistent urge to defecate that remains even after the rectum is empty, and the bowel movements are small and frequent. Notice that carefully. Small and frequent, not large and voluminous. Because the rectum is inflamed and stiff, it cannot hold normal volume, so the patient goes often and passes very little each time. Contrast that with small bowel disease, which gives large volume, watery stools. Here is a number worth remembering. More than 25% of patients with ulcerative colitis have manifestations outside the colon. That is a large minority. Some of these track with bowel disease activity, flaring when the colitis flares and settling when it settles. Others run an entirely independent course and will not improve when you treat the gut. So you have to ask about skin, eyes, joints, and liver at every single visit. And be aware that sometimes the extraintestinal problem is what brings the patient in first, before the diarrhea is ever mentioned. Some appear years before the bowel disease ever declares itself. Start with the skin and mucosa. Erythema nodosum is a paniculitis. Tender red nodules classically over the shins, and it usually tracks with bowel disease activity. Pyoderma gangrenosum is a neutrophilic dermatosis, a rapidly enlarging painful ulcer with a violaceous undermined edge. And here is the trap. Do not debride it. Surgical trauma makes pyoderma gangrenosum worse through a phenomenon called patchy. And diaphyseal ulcers are painful shallow mouth ulcers that flare alongside the colitis. 3 skin and mucosal findings, all worth recognizing on site. Ask patients directly about mouth ulcers. They rarely volunteer them. Now the eye, the joints, and the blood. Uveitis threatens vision and needs urgent ophthalmology referral. Episcleritis is milder, and it tends to track with bowel flares. In the joints, seronegative arthritis is the most common extraintestinal manifestation of all, and seronegative means the rheumatoid factor is negative. Do not let that reassure you into dismissing it. And in the blood, patients have an increased risk of thromboembolic events, highest during an active flare, as well as autoimmune hemolytic anemia. That thrombotic risk is often underestimated on the wards. Prophylactic anticoagulation in a hospitalized flare is standard, and it is safe even with rectal bleeding. Primary sclerosing cholangitis deserves its own slide. It is progressive fibrosing inflammation of the bile ducts, and it is the one extraintestinal manifestation that brings its own cancer risk with it. It raises the risk of cholangiocarcinoma, cancer of the bile ducts, and separately it raises the risk of colorectal cancer, independently of how much colon is involved by the colitis. So a patient with ulcerative colitis and primary sclerosing cholangitis carries 2 distinct malignancy risks, neither of which the colitis alone would predict. It is more common in ulcerative colitis than in Crohn disease. Why does that change your practice? Because primary sclerosing cholangitis runs an independent course from the bowel disease. Treating the colitis does not treat the liver, And colectomy does not make the liver disease go away. The cancer risk is doubled in two directions, biliary and colorectal. So in a patient with both conditions, surveillance colonoscopy starts sooner and repeats more often than the usual schedule. Here is the practical rule. A cholestatic liver panel in a patient with ulcerative colitis is primary sclerosing cholangitis until proven otherwise. Do not blame the medications first. Screen with alkaline phosphatase. It is usually the first test to move. Now severity. 3 scoring systems come up. Truelove and Witts is the bedside score. It uses stool frequency, the presence of blood, fever, tachycardia, anemia, and the sedimentation rate, and it sorts mild from severe quickly with information you already have. The Mayo score, also called the Disease Activity Index, adds endoscopic findings and a physician global assessment, and it is the score used in clinical trials. And the Montreal classification describes anatomic extent alongside severity. That is the language you will see in gastroenterology referrals. Pick one and use it consistently. The value is in tracking the same score over time. So how sick is our patient? Run her through the bedside score. She has 6 to 8 bloody stools a day, which alone puts her out of the mild category. Her temperature is 37.8 and her pulse is 98, so she has systemic signs. Her hemoglobin is 10.2. She is anemic. Her sedimentation rate is 55, and her albumin is 3.1. Put the frequency, the systemic signs, and the inflammatory markers together, and she lands in the moderate to severe range. That matters, because it changes both urgency and therapy. And she has no features of toxic megacolon, no distension, and no severe systemic toxicity. How do we make the diagnosis? Colonoscopy with biopsy is the test. And there is a pattern you are looking for. The rectum is involved in 95% of patients. From there, the disease extends proximally, circumferentially, and continuously. There are no skip areas. Say that again. No skip areas. That unbroken pattern, starting at the rectum and moving up without interruption, is itself the diagnosis. If the endoscopist describes normal mucosa between patches of inflammation, you are looking at Crohn disease, not ulcerative colitis. One caveat. Treated disease can produce apparent rectal sparing, so ask about prior therapy. Once you know the disease is there, you classify it by how much colon is involved. Proctitis means disease limited to the rectum, and that accounts for 30 to 60% of patients, the largest group. Left-sided disease extends from the rectum up to the splenic flexure, and that is 15 to 45%. Extensive disease, also called pancolitis, involves the colon beyond the splenic flexure, and that is 15 to 35%. Extent is not academic. It drives both the route of therapy, topical versus oral, and the cancer surveillance schedule. Proctitis is often managed with topical therapy alone, which is a real advantage. What does the endoscopist actually see? First, loss of the normal vascular pattern. In a healthy colon, you can see fine submucosal vessels through the mucosa. In colitis, that pattern disappears because the mucosa is swollen. Second, friable mucosa that bleeds when the scope simply touches it. Third, diffuse ulceration, and note diffuse, continuous rather than patchy. And fourth, pseudopolyps, which are islands of regenerating mucosa left standing between ulcers. Pseudopolyps signal chronicity. This has been going on a while, and importantly, they are not neoplastic. Note that severity is graded on what is seen, which is why endoscopy sits inside the Mayo score. Now the histology. The pathologist sees superficial chronic inflammation, limited to the mucosa, which is exactly what the definition promised. You will see crypt abscesses, collections of neutrophils inside the lumen of the crypts, and architectural distortion. The normal orderly parallel crypts become branched and irregular. And here is what you should not see. No granulomas, and no transmural involvement. So the picture I script abscesses, plus architectural distortion, without granulomas. If a granuloma appears on the report, reconsider the diagnosis. Biopsies should be taken from multiple segments, including normal-appearing mucosa. One classic image worth knowing. On barium enema, the colon appears featureless and tubular, and this is described as the lead pipe appearance. Here is why it happens. Chronic repeated inflammation destroys the haustral folds, the normal segmented pouches of the colon. Once those are gone, the colon becomes a smooth, rigid tube with no internal markings. We rarely order barium enemas now. Colonoscopy has replaced them. But the lead pipe colon remains a classic examination image, and it tells you the disease is long-standing. It also tells you the colon has lost its reservoir function. What about markers during a flare? The sedimentation rate and C-reactive protein both rise, but be careful with them. Neither is sensitive nor specific. A normal C-reactive protein does not exclude an active flare, and a raised one does not confirm it. Fecal calprotectin is more useful. It is released by neutrophils in the gut wall, so it reflects actual mucosal inflammation. It is genuinely helpful for distinguishing inflammatory bowel disease from irritable bowel syndrome, and for monitoring a patient you already know has the disease. So never manage a flare on a laboratory number alone. the patient in front of you outranks it. Now a rule with no exceptions. Before you call a change in symptoms a flare, you must rule out infection. C. difficile is the organism that most often masquerades as a flare, and patients with inflammatory bowel disease are at higher risk for it, even without recent antibiotics. Send routine stool culture, and ova, and parasites as well. Here is the error you are trying to avoid. Escalating steroids or a biologic into an untreated infection. That turns a treatable colitis into a critically ill patient. Test first, then escalate. Cytomegalovirus colitis is the other one to remember in steroid refractory disease. Now the complication that kills? Toxic megacolon occurs in about 5% of patients. It is defined by colonic dilatation of 6 centimeters or more on a plain abdominal film, accompanied by colonic atony and systemic toxicity, and it carries a sharply increased risk of perforation. Here is the bedside trigger, a patient with known colitis who develops fever, tachycardia, and a distending abdomen. Get the film now. And note something counterintuitive. As the colon dilates and goes atonic, the diarrhea may actually decrease. Do not read that as improvement. And avoid opiates and antidiarrheals in severe colitis. They can precipitate it. Managing toxic megacolon. Start intravenous steroids to suppress the inflammation. Add broad-spectrum antibiotics, because the dilated atonic colon translocates bacteria and perforation may already be developing. Then follow the patient closely. Serial abdominal films to track the diameter, and serial examinations by the same person where possible, so changes are real. And proceed to surgery if there is no rapid improvement, or immediately at any sign of perforation. The single most common error here is involving surgery late. Bring them in at the beginning. Total colectomy is the operation performed when surgery becomes necessary. Beyond toxic megacolon, there are 3 more complications. Stricture can develop after recurrent inflammation, typically in the rectosigmoid. Dysmotility follows repeated cycles of inflammation and healing. And anorectal dysfunction results from chronic rectal inflammation. Patients can be left with urgency and incontinence, even when the disease itself is quiet. Now one firm rule about strictures. Any stricture in ulcerative colitis must be biopsied. Malignancy has to be excluded before you accept that a narrowing is simply scar tissue. Chronic urgency after remission is a quality of life issue worth asking about directly. Now cancer risk. Patients with ulcerative colitis have an increased risk of colorectal cancer and dysplasia after 8 years of active disease. That 8-year mark is when surveillance colonoscopy begins. Risk rises with the duration of disease and with the extent of colon involved. So a patient with pancolitis carries more risk than a patient with proctitis. What surveillance is actually hunting for is dysplasia, not established cancer. And remember the modifier from earlier, concurrent primary sclerosing cholangitis, moves the start date earlier. This is why a colitis patient never simply returns in 10 years. Pouchitis is the complication after surgery. When the colon is removed and an ileal pouch is constructed, up to half of those patients will develop inflammation of the pouch itself. It presents with increased stool frequency, urgency, bleeding and cramping. In other words, it looks like the disease came back. Treatment is antibiotics, metronidazole or ciprofloxacin, usually with probiotics added. And here is the message for patients. Colectomy cures the colitis. It does not end the follow-up. There is still a pouch to look after. Recurrent or chronic pouchitis sometimes needs longer-term therapy. Now the prognosis numbers. About 50% of patients are in remission at any given moment. 90% will have intermittent exacerbations over time, so relapse is the rule rather than the exception. Roughly 18% have continually active disease that never fully settles. And 25% show proximal progression by 10 years, meaning the disease extends further up the colon than where it started. That last number is worth knowing. The extent you document a diagnosis is not necessarily the extent 10 years later. Set that expectation early. Patients who expect a cure feel failed by a relapse. 2 more numbers finish the prognosis. The rate of colectomy at 10 years is 24%. So roughly 1 in 4 patients comes to surgery within a decade of diagnosis. That is a real number, and patients deserve to hear it honestly. But now the number that reassures. The mortality rate of a severe ulcerative colitis flare is under 2%. And overall life expectancy in ulcerative colitis matches that of people without the disease. Say both of these out loud to patients. The diagnosis is serious, and it is chronic, but it is not a shortened life. A colectomy is not a failure of care. For some patients, it is the treatment that gives them their life back. This table is worth memorizing. Read down the 2 columns. Depth. Ulcerative colitis is mucosa only. Crohn is transmural. Distribution. Ulcerative colitis is contiguous from the rectum. Crohn produces skip lesions. Location. Colon only versus mouth to anus. Diarrhea. Grossly bloody versus often non-bloody and mucus containing. Perianal disease. Absent in ulcerative colitis. Fissures, fistulas, and abscesses in Crohn. Granulomas. Absent versus non-caseating in under a quarter of biopsies. And the classic complication, Toxic megacolon versus stricture, fistula, and abscess. Around 10% remain unclassified at diagnosis, and that is an honest answer. The pitfalls that cost patients. First, calling bloody diarrhea with tenesmus and irritable bowel syndrome. Functional disease does not produce blood and does not wake people at night. Second, escalating immunosuppression before ruling out C. difficile. Third, missing toxic megacolon because the abdomen was examined once at admission and not again. Fourth, treating a cholestatic liver panel as a drug effect rather than working it up for primary sclerosing cholangitis. And fifth, letting a colitis patient default to a 10-year colonoscopy interval. After 8 years, the rules change. And sixth, forgetting to examine the perineum. It is a 2-minute exam that changes the diagnosis. Back to our patient. Her colonoscopy was performed with segmental biopsies throughout. The rectum was involved and the inflammation was continuous, with no skip areas anywhere. Disease extended up to the splenic flexure and stopped there, which makes this left-sided disease. The vascular pattern was lost, the mucosa was friable, and there was diffuse ulceration, and the histology returned crypt abscesses with architectural distortion and no granulomas. Every finding lines up. This eye's left-sided ulcerative colitis, moderate to severe by her clinical score. There was no ileal involvement on the terminal ileum intubation. So here is the assessment and plan. Left-sided ulcerative colitis, moderately to severely active. Infection was excluded before any immunosuppression was started, which is the step you never skip. We check a liver panel now to screen for primary sclerosing cholangitis, because finding it changes her surveillance schedule for life. Her colorectal cancer surveillance clock starts 8 years from diagnosis, and we document that in the chart today so it is not lost. Drug selection by severity is a topic of its own, and it is covered in the IBD management video. We also counsel her on the thrombotic risk during flares, and on smoking, which she does not do. Let us bring it together. Ulcerative colitis is mucosal, contiguous, colon only, and it starts at the rectum. It presents with grossly bloody diarrhea, tenesmus, and small frequent stools. More than a quarter of patients have extraintestinal disease, and primary sclerosing cholangitis is the one that carries its own cancer risk. Colonoscopy with biopsy makes the diagnosis, crypt abscesses, and architectural distortion without granulomas. Toxic megacolon is dilatation at 6 centimeters, treat with steroids, antibiotics, and early surgical involvement. And cancer surveillance begins after 8 years of active disease. These are the sources behind today's material. The clinical picture, diagnosis and complications follow the current JAMA review of ulcerative colitis. The definitions and overview of inflammatory bowel disease follow the New England Journal review. The epidemiology and pathophysiology follow the Lancet reviews. The thromboembolic risk data come from Lancet, and the role of fecal calprotectin comes from gastroenterology and hepatology. Thanks for working through this one. Remember the 3 words, mucosal, contiguous, and rectum. Crohn disease is the next video in this series. See you there. All numbers quoted today come from those sources.